Hi everyone, my name is Dan and I'm a mental health pharmacist, and today I will be doing a presentation on dementia and delirium. I have three major objectives, so hopefully by the end of this presentation you'll be able to identify the different neurocognitive disorders in the DSM-5, interpret the risk factors, etiology, and more for the different neurocognitive disorders, and then finally demonstrate the ability to recommend non-pharmacologic and pharmacologic treatments for the various types of neurocognitive disorders. I will be following this table of contents slide throughout my presentation. First, I'll start with a little bit of background, then I'll go into more specific the major two sections of neurocognitive disorders, which is delirium and then dementias or the neurocognitive disorders. And finally, I will end with behavioral and psychological symptoms of dementia. So without further ado, let's get into the background. The first question is, what is a neurocognitive disorder? So a neurocognitive disorder is an umbrella term that the DSM uses. Remember, the DSM is the manual that psychiatrists use to standardize the diagnosing of mental illnesses. And there's a whole chapter on neurocognitive disorders. Within this chapter, the two major sections are delirium and then major and mild neurocognitive disorders, which were previously called dementias. The DSM is getting a little bit away from using the term dementia, and they prefer neurocognitive disorders. But in real life and in research and in practice, either of these terms can be used. One of the distinctions with the neurocognitive disorders is that the primary deficit is cognitive. Cognitive deficits are seen in many mental illnesses, such as schizophrenia, bipolar, and so on, but they aren't the primary deficit. Whereas with neurocognitive disorders, the primary deficit is neurocognitive. These must be acquired rather than developmental, additionally. So remember that within the DSM-5, neurocognitive disorders is an umbrella term, and there's many different types of neurocognitive disorders. First question is, what is the difference between delirium and dementia? So feel free to pause, take a second to think it over. But the major difference is that delirium has a sudden, abrupt onset, and dementia has a slower onset. And there are additional components as well that could be considered correct answers. So finally, I wanted to show you all the breakdown that the DSM-5 has to offer. So within the DSM-5 neurocognitive disorders chapter, first you have delirium with a few subtypes and more specific diagnoses you can make. But you also have the major and mild neurocognitive disorders section, which includes a lot of familiar terms like Alzheimer's disease. So a lot of people would call it Alzheimer's dementia, but according to the DSM, it's major and mild neurocognitive disorders due to Alzheimer's disease. A lot of people would call it Lewy body dementia, according to the DSM, major and mild neurocognitive disorders due to Lewy body disease, and so on. So again, it's just naming, but I wanted to show you that these terms is how it's defined within the DSM. There's many other types of neurocognitive disorders due to traumatic brain injury, prions disease, mixed etiologies, and so on. But the ones that are bolded are the ones that we're going to be highlighting today. So that's all I had for the background section. I just wanted to set the scene with what these terms meant, show the umbrella term, and show these different classifications within the DSM-5. But then my real goal is to go more in detail into delirium and then the neurocognitive disorders and show how to treat these conditions. So let's go into delirium now. I'll start with the DSM-5 criteria, more specifically for delirium. So it starts with a disturbance in attention, but also includes a disturbance in cognition, and then the time frame is important. So delirium develops over a short period of time, and the disturbances cannot be explained better by another condition. Rating scales are great to use in psychiatry, so we don't always have those objective measures to use because you're using subjective symptoms. So putting a number and a score using a rating scale can be really important. One of the most common scales that I've seen is called this confusion assessment method for the ICU. CAM-ICU is what it's shortened to. And it has some really interesting questions. So it looks for inattention. So you'll hold the patient's hand and spell a word, like the examples here are save a heart, but heart is spelled with two A's. And every A that you read, the patient's supposed to squeeze your hand, and it shows if they're able to pay attention and follow the letters. There's additional questions too that are quite interesting that look for disorganized thinking. So it asks questions such as, will a stone float on water? Are there fish in the sea? Does 1 pound weigh more than 2? And can you use a hammer to pound a nail? So pretty interesting questions to check if someone has delirium. The etiology of delirium is multifactorial. So there's many different conditions, whether it be an electrolyte disturbance, a glucose disturbance, an infection. Many things can cause delirium. The incidence is quite high, as you can see. So many patients that are admitted to the hospital have delirium or develop delirium. Even a higher percentage of the ICU patients have delirium. One thing to note here are there different subcategorizations of delirium. So there's hyperactive delirium, hypoactive delirium, and mixed. As you would imagine, hyperactive delirium is often the most commonly diagnosed because these patients have a lot of motor movement, agitation, things like that. So it's easier to spot and they're more troublesome to the nurses and the staff. Whereas someone with hypoactive delirium can be quiet and just confused and having the symptoms of delirium, but they're not causing a problem for anyone, so it's not found as often. So it's really important to use those scales and check for delirium, even if a patient's just quiet and not really bothering anybody. Another cause of delirium is polypharmacy, so responsible for 39% of cases. So if you have an older patient or someone at risk for delirium, and you have them on benzodiazepines and anticholinergics and opioids and other sedatives, there's a good chance that that can contribute to a confused state. So pay really important attention to that. And there's other factors too that can cause issues with delirium. The pathophysiology is unknown. Delirium's complicated and we don't understand why such a high percentage get it, but also why many people don't get delirium. Next, let's look at the treatment. So we'll look at 2 sets of treatment guidelines and compare them and see what they say and how to treat delirium. So first, we'll look at the Society of Critical Care guidelines. And there's 2 major sections to this, delirium prevention and delirium treatment. So for delirium prevention, they recommend non-pharm interventions. So what are the non-pharm interventions for delirium? And these are mainly orienting the patient as best as you can. So for example, if a patient needs hearing aids, give them their hearing aids. If a patient needs glasses or reading glasses, give them their glasses. When it's daytime, have their lights on. When it's nighttime, have their lights off. Have a calendar in the room, write the date, write the season, write the weather, things like that to orient the patient to where they are. So having a toolbox like that can be really helpful to reorient the patient and keep them from developing delirium or becoming more confused. In regards to prevention, they recommend against a lot of the medications. Haloperidol, which is a first-gen antipsychotic, atypical antipsychotics, dexmedetomidine, statins, ketamine, recommends against all of them. Delirium treatment is much the same. So you want to do those non-pharm options. You can use dexmedetomidine in mechanically ventilated adults, and it recommends against haloperidol, atypical antipsychotics, or statins. Let's compare this to the NICE guidelines out of the UK. So delirium prevention, they recommend pretty much the same. So non-pharm options and then low quality evidence for medications. Delirium treatment, much the same as well. Non-pharm options, little evidence for medications. If you've worked with patients with delirium, you will often see antipsychotics used regardless. So one thing that the guidelines have is like a little caveat or a little side notice is that if the patient's having hallucinations, delusions, severe agitation, or things like that, a short-term course of antipsychotics can be used. Again, the evidence isn't that strong, the guidelines aren't really pushing them, but in real practice you will see this used. So we've looked at what the guidelines say, let's look at what the actual medical evidence, what the papers say. So here's a meta-analysis of 19 trials where it clumps them all together and looks at the data. And they found that antipsychotics had no statistically significant effects on delirium incidence, duration, severity, hospital length of stay, ICU length of stay, mortality. So not looking great in this regard. That being said, all the evidence isn't negative. So here's a trial that used a validated delirium scale, looked at their baseline scores, which were quite high, 19, 18, 19, 18. put them on an antipsychotic for a week, and their scores were much lower. That being said, there was no placebo group, so did the patients improve because a week had passed, or had they improved because of the medication? It's hard to predict. It's impossible to predict, so unsure. So the guidelines don't really say to use antipsychotics. The evidence isn't particularly strong, but again, you will see this used in real practice if a patient's really agitated or violent or aggressive or having hallucinations or something like that. So I wanted you to be aware of this. Next, let's look at benzodiazepines. So there's not good controlled trials that support the use of benzodiazepines in patients with non-alcohol withdrawal delirium. So if a patient has alcohol withdrawal, you're going to use benzodiazepines. They're really helpful for that disease state. They're going to prevent a seizure and so on. But if a patient doesn't have that and has delirium, there's really not much evidence to use a benzodiazepine. It may in fact even worsen or prolong the delirium. Next is melatonin or Ramelteon. So these Ramelteon is essentially like a brand name product that works relatively similar to melatonin. It works on the same receptors, it's more potent though. And they found that using these agents may reduce delirium incidence, so it may help to prevent delirium. As you can see, 49% risk reduction in surgical patients, 34% risk reduction in ICU patients. So in the case of melatonin, relatively cheap agent that can really help patients in preventing their delirium. So this might be a good option if you have someone at risk. So that's what I wanted to show with delirium. So we went through the definition of what it was, the DSM-5 criteria, we went through the guidelines, we went through some of the medication evidence, and that's what I wanted to show with it. So now let's go into the next section of the presentation, which is neurocognitive disorders. So there is a DSM-5 criteria section just for general neurocognitive disorders. So this is what it is here. Evidence of significant cognitive decline from baseline in regards to learning, memory, language, so on. They interfere with everyday activities. They do not occur exclusively in the content of delirium, and so on. But you're not done once you determine someone has a neurocognitive disorder, because you have to specify which neurocognitive disorder it is. Alzheimer's disease, frontotemporal dementia, Lewy body disease, vascular disease, and so on. There's many options here. So what we're going to go into is some of these bolded types and go through some of the more common types that have treatments. Just like for delirium, there are rating scales for dementias, for the major and mild neurocognitive disorders as well. Some of the really common ones are mini mental state exam, or some people call it mini mental status exam, MMSE. And then this picture here is of the MoCA, the Montreal Cognitive Assessment. This scale here is free to use, the MoCA, so I see a lot of med students using this and a lot of people using this scale. So let's briefly look at the scale. So it's quite interesting. So it has some visual spatial tests like this 1A, 2B, 3C pattern. You have to copy a cube, draw a clock, name some animals. Then it has a nice little memory test on there. So you provide the patient with the terms or the words face, velvet, church, daisy, red. And then they have to repeat them back to you. Then you complete the rest of the MoCA and then go back to them 5 minutes later and see if they can remember those 5 words. Face, velvet, church, daisy, red. And there's more questions here on the scale. So now let's go more in depth into the different types of major and mild neurocognitive disorders, and we'll start with Alzheimer's disease. So just like there's criteria for neurocognitive disorders, there's more specific criteria just for Alzheimer's disease. So this shows here the DSM-5 criteria. So first you have to meet the criteria for a major or mild neurocognitive disorder, and then you can go more specifically into Alzheimer's criteria. So what they're looking for here is insidious onset, gradual progression of impairment, and then you're looking for either a probable diagnosis or a possible diagnosis. A probable diagnosis can be made if someone has a genetic test or a family member has a genetic test where you can identify these genes. The most, as you can see in the image on the right, the most common one that I hear about is this APOE4 APOE4 gene. Next, if you don't have genetic tests, you can make a probable or a possible diagnosis if they meet the criteria below. Etiology is multifactorial. Increasing age is really common. Genetic risks, of course, Down syndrome, head trauma, depression. The incidence increases with age. So at age 65, roughly 1 to 2% of people have Alzheimer's disease. At age 85, roughly 30% of people have it. Pathophysiology here is interesting, and a fair bit is known about it. So two major things. There's two major proteins that can develop out of control and become toxic to the brain. First, we have the amyloid beta protein, then we have the tau protein. So what happens is the amyloid beta protein, when it grows out of control, can lead to plaque development. This is outside the neurons, in between the neurons, gets in the way of the neurons working correctly. But not only does Alzheimer's disease attack from the outside, the tau protein also attacks from the inside the neurons by developing into neurofibrillary tangles. So there's plaques on the outside, tangles on the inside cells, and the neurons can't work very well. Also, in regards to the pathophysiology, and this is important because this is how a lot of our medications work, is that there will be decreased acetylcholine activity, which can lead to neurons not communicating very well, and excessive glutamate release, which can lead to neuronal death. Treatment guidelines can be seen here. So there is a little bit of non-pharm things that can be done, such as cognitive stimulation, group therapy, cognitive rehabilitation, but most of the guidelines recommend acetylcholinesterase inhibitors, memantine, or possibly a combination of acetylcholinesterase inhibitors and memantine. So, question for you. When we went through the MOCA scale, there were 5 words to remember. So see if you can remember those 5 words. Roughly 5 minutes has passed, so that would be when you would ask the patient for the second round. So feel free to pause and think about it. And the words were face, velvet, church, daisy, red. Okay, so that's what I wanted to show with Alzheimer's disease. Now let's look at vascular dementia. DSM-5 criteria is listed here, but vascular dementia is essentially dementia that occurs after a cerebrovascular event. So someone has a stroke or something like that, and then their neurocognitive functioning isn't as well as it used to be. This doesn't happen to everyone that has a stroke, but when it does happen, it's called vascular dementia. Major risk factors are the same as the risk factors are for stroke. So someone has AFib, diabetes, hyperlipidemia, hypertension, so on. You want to prevent these things or treat them early so that the person doesn't develop a stroke. If they don't develop a stroke, then their chances of getting vascular dementia go down extremely greatly. There's also a genetic risk, of course. Pathophysiology can be seen here. Multiple causes, so large vessel dementia, small vessel dementia, but other things like hyperperfusion or hemorrhagic dementias can all contribute. Next, a brief slide about the treatment and the guidelines. The APA guidelines and the BAP guidelines don't really offer specific recommendations for vascular dementias, or when they do, they don't really recommend medications. So our goal here is mostly prevention. But let's not just base everything off the guidelines. Let's look at a little bit of evidence as well. And we can see here that for vascular dementia, there was a trial with acetylcholinesterase inhibitors, and they provided limited benefit. So the change was unlikely to be clinically significant, and the patients had increased side effects. Next is Lewy body dementia. DSM-5 criteria can be seen here. And there's some very specific things that lead to a probable cause of or a probable diagnosis of Lewy body dementia. And that's symptoms of Parkinsonism, so Parkinson's disease-like symptoms, and visual hallucinations. So if a patient has cognitive decline, Parkinson's disease, and visual hallucinations, you can be pretty sure that it's Lewy body dementia. Risk factors can be seen here. Male is a greater risk factor, and then the prevalence can be seen as well, 10 to 25% of all cases. Just like in Alzheimer's disease, how there's proteins, the beta amyloid protein and the tau protein that get out of control, With Lewy body dementia, it's alpha-synuclein protein. So this is the same protein that's elevated in Parkinson's disease, so this can be this is why those symptoms cross over quite a bit. Now let's look at the treatment guidelines. So for first line, you have some non-pharm options, but really you're going to be looking at medications as well. So these acetylcholinesterase inhibitors pop back up, and then memantine is generally a second line, as compared to Alzheimer's where it can be a first line option. The final type we'll go into more detail is frontotemporal dementia. So here's the DSM-5 criteria for frontotemporal dementia. So the criteria are met for milder major neurocognitive disorder. And then what you do see is a relative sparing of learning and memory, but you will see behavioral changes or language changes. Frontotemporal dementia, as you would expect, the issues are in the frontal lobe and the temporal lobe. Pathophys is not completely known, but there is an abnormal protein aggregate, just like in Lewy body dementia, just like in Alzheimer's dementia. And treatment guidelines can be seen here. The NICE guidelines say don't offer meds, but the BAP guidelines do say you can try acetylcholinesterase inhibitors or memantine. So there's mixed evidence here with frontotemporal dementia. Finally, there are many other types of neurocognitive disorders. So here's a listing here of many of the other types that we're not going to go into detail about. Now let's go into the medications for neurocognitive disorders. So I've mentioned some of these, but we haven't gone into detail about acetylcholinesterase inhibitors, NMDA antagonists, or the amyloid beta-directed antibody. First, we have acetylcholinesterase inhibitors. So the three options we have here are donepezil, galantamine, and rivastigmine. So acetylcholinesterase is the enzyme that breaks down acetylcholine, which is low in people with dementia. So when you block the enzyme that breaks down acetylcholine, you thereby increase acetylcholine, which can increase neuronal function. So that's how these medications work. How to pick between them? So they work relatively the same. So their efficacy rates are about the same. Some say, and a little bit of evidence supports that donepezil might be the best tolerated, but they're relatively similar. When you're picking between the three, formulations can be helpful to know. So donepezil is just available as oral products, galantamine is oral and solution, and rivastigmine is oral, solution, and patch. So they kind of all one-up each other. They have slight differences in their mechanism, but you can look further into that if you're interested. Some warnings here are peptic ulcer disease, GI bleeds, so you want to worry about other things that can increase the risk for GI bleeds like NSAIDs. Some of the side effects can be seen here, including diarrhea can be quite severe, weight loss can be quite severe, so it can cause an anorexia. Not anorexia nervosa, the eating disorder, but a sudden severe weight loss. Here's some of the literature, and one of the downsides or issues with acetylcholinesterase inhibitors is that they don't work for years and years and years. Most of the evidence shows that they work for maybe 6 months, 9 months, a year, and they prevent the dementia from getting worse, but they're not a cure for dementia or anything like that. They just slow the progression for about 6 months to a year, buy the person who's having the dementia more time to get their affairs in order and so on. So it's quite a sad disease progression. This trial here showed that 2 out of 10 patients showed a response at 3 months, and only 1 out of 10 maintained that response at 9 months. So these medications aren't miracles, but they can help a small percentage of patients. This trial here was looking at the direction of improvement, and these were patients on donepezil. They either continued donepezil, discontinued donepezil and started memantine, or continued donepezil and started memantine. And as you can see from the graph, the direction of improvement is up and everyone is decreasing. So all the groups were declining, but the group that stopped all the medications declined the most. So the medications helped to slow that decline. So now that we talked about acetylcholinesterase inhibitors, let's talk about the NMDA antagonist, which there's only one, memantine, brand name Namenda. Mechanism of action is it's an NMDA receptor antagonist. So if you remember, there was excessive NMDA activity, which can cause excitotoxicity or neurotoxicity. So this prevents that from happening, that toxicity from happening. Warnings and precautions. So there's a warning for patients with seizure disorders, and the adverse effects, some are listed here. Memetine's generally fairly well tolerated. Here's some literature, a meta-analysis of 9 trials that showed improvement with memantine for Alzheimer's disease. The improvement was relatively mild, but it did exist in many of the trials, so there is a mild improvement with memantine. The final med that we'll go over is an amyloid beta-directed antibody. So this is called aducanumab, brand name Aduhelm, and this is, as you can tell from the name being mAb, this is a monoclonal antibody. This is directed against the specific protein, the beta amyloid protein, and prevents and degrades those plaques that form in the brain. So people were really excited when this medication came out because this is hitting the core pathophysiology, the core cause of Alzheimer's disease. Before you use this, you have to confirm that they have those amyloid pathology because that's how this med works, by breaking down those plaques. So you get a PET scan, MRI scan, things like that. Dosing can be seen here. This is an IV infusion that's given every 4 weeks. There is a big controversy with Aduhelm. So there was an FDA advisory board, and 10 out of 11 members of the FDA advisory board recommended against approving this medication. That being said, the FDA approved it regardless, and a few members of that board resigned over the controversy of approving this med. So many people didn't think it was ready, didn't want it to be approved, but the FDA approved it. One of the big issues with this medication is some of its side effects. So there's a warning called amyloid-related imaging abnormalities, or ARIA. And this doesn't sound too bad in its name, just imaging abnormalities, but in what the imaging abnormalities are, it can be quite scary. So there's ARIA-E, which is edema. This medication can cause brain edema, and ARIA-H, which is microhemorrhaging. And this happened in a very significant amount of patients. So roughly 30 to 40% of patients had ARIA. That being said, most of the patients weren't symptomatic, but still, anytime there's brain edema or brain hemorrhaging, that can be quite scary of a side effect. So I can understand the concern with approving this medication. Let's look at the literature. So there were 2 major trials, Emerge and Engage, and they were halted based on a futility analysis. One of the trials did end up meeting its primary endpoint, but the other didn't. Okay, so I hope that was helpful going into the medications. Now let's go into some medications that can contribute to neurocognitive disorders. So first I wanted to show this trial on the right, looking at anticholinergic drug exposure and degree of dementia. Really, really big trial, 58,000 patients in the nested case control, and then 200 with dementia, and then 225 control patients. There was a 50% increase odds of dementia when a single strong anticholinergic was used for 3 years. And this was anticholinergics in many different classes. Antidepressants, anti-Parkinson's drugs, antipsychotics, so on. The trial on the right showed a risk of dementia in long-term benzodiazepine users. Meta-analysis of 10 trials showed a relative risk of 1.51. Risk was higher with longer half-life benzos and using these medications for 3 years or longer. So long-term use of anticholinergics, long-term use of benzodiazepines can contribute to dementia risks. The final section is behavioral and psychological symptoms of dementia. So when you treat someone with dementia, you're often not just treating the actual dementia, you're treating these behaviors or aggression or violence that goes along with dementia. So this section here has a few slides about this. There's no specific diagnosis for behavioral and psychological symptoms of dementia. In the DSM-5, you will see with behavioral disturbances. So this is when the neurocognitive disorder is accompanied by agitation, aggression, things like that. Treatment, first you want to do non-pharm things. So rule out other causes, rule out other disease states, redirect, diffuse the patient. So for example, if your patient with dementia is getting angry or aggressive or violent, give them a task to do. Have some unfolded towels, have them help you fold the towels. remove coats and hats and things like that that make the patient think they're leaving the unit, so making them feel safe and secure in their environment. Having a routine, a consistent schedule can all be really helpful. Pharmacologic, there are some medications that can be used. This suvorexant, it does have FDA packaging related to using this in insomnia, whereas the other ones do not have FDA approval or FDA packaging. So now I wanted to go into the individual medications, but there is a black box warning on antipsychotics and dementia-related psychosis. So the question here is, what is a medication black box warning? And then what is the black box warning on antipsychotic medications in dementia? So feel free to pause and think about it. So a medication black box warning is a literal black box bolded font on the package insert that the FDA wants you to be aware of before you use a certain medication. This is not specifically a contraindication. The medication still can be used. They just really want you to be aware of this warning. So what is the black box warning on antipsychotic medications in dementia? It's increased mortality. It's increased risk of death, so it's very severe. Here is the black box warning, and here's what it says. So antipsychotics still can be used in dementia-related psychosis, but you really only want to use this if the patient's really aggressive, sexually inappropriate behaviors, things like that. You don't want to use it for minor causes, and document things really thoroughly. Antidepressants can be used. These are commonly used if a patient has depression, agitation, things like that. Mood stabilizer, little evidence, can be used. Acetylcholinesterase inhibitors probably will be used just because the patient has dementia, but little evidence specifically for the behavioral and psychological symptoms of dementia. If a patient has inappropriate sexual behaviors, you're going to do non-pharm things like distraction, or if the patient prefers female staff, you might only have male staff come in and help them and work with them. But you can also use some medications. So antidepressants are commonly first line. Antipsychotics have case reports. Anticonvulsants are sometimes used. And hormonal agents are controversial. So some people refer to that as chemical castration, which is, as you would imagine, controversial. So this is the table of contents slide. We went through a background of neurocognitive disorders. We went through what delirium is. Then we went through the neurocognitive disorders, and more specifically a few of them, such as Alzheimer's disease, Lewy body disease, vascular dementia, frontotemporal dementia. And finally, we ended with behavioral and psychological symptoms of dementia. So I hope we reached those objectives. I hope the presentation was helpful, and thank you so much for watching.